Welcome to today's iReview session. My name is Yejun, a second-year medical student at the University of Calgary. Our team here will present to you today the ophthalmic changes in schizophrenia as a link between ophthalmology and psychiatry. The two links between schizophrenia and the eyes that will be explored in this presentation is first the abnormal eye movements, and second the retinal abnormalities, or also known as retinopathies. In abnormal eye movements, there are different levels of eye movements that can go wrong, from reflexic eye movements to conscious control from the brain that moves the eye in an organized fashion to take in visual information. So more specifically, some of the examples we will explore is the impaired smooth eye pursuit movements and the limited exploratory eye movements. In terms of retinopathies, there are three solid findings in literature. First is the wider retinal venules for those with psychosis, and the thinning of a layer called retinal neural fiber layer, as well as reduction in the macular volume and area. And lastly, the increased perception of brightness and color intensity. This, in turn, also decreases contrast sensitivity. So before we delve further into making this connection between schizophrenia and the eyes, it's important, I think, to know what schizophrenia is. So schizophrenia is a psychiatric disease with psychosis that significantly impacts an individual's function. And while schizophrenia as a word means the splitting of the mind, schizophrenia does not mean a splitting of personality. Rather, schizophrenia describes an array of psychosis-related symptoms and behaviors. Schizophrenia is also a syndrome associated with many different symptoms associated with that, and it also has individual variations. And the symptoms are, as seen in these two pictures, classified into positive symptoms, negative symptoms, as well as cognitive ones, and we will explore this more in the next few slides. So there is a very important manual that psychiatrists often refer to, and this is called DSM-5, or the Diagnostic and Statistical Manual, the 5th edition. And this describes schizophrenia as a syndrome with two or more of the following 5 symptoms: delusion, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, and negative symptoms. And one important point is that at least one of the symptoms that the patient is experiencing has to be one of the 3 bolded bullet points: delusions, hallucinations, and disorganized speech. Delusion is a firm belief in a concept or an idea, despite any evidence that might be to the contrary. So for example, the FM radio is a message transmitted by aliens. That could be one example of a delusion. Hallucination is a sensory perception despite the source of the perception not being existent. So we have 5 senses, and the most common for schizophrenia is an auditory hallucination, where you hear noises or someone whispering or talking to you, despite there not being any sound in reality. There can also be visual hallucinations, where the patient see things. And there are also haptic or somatic hallucinations, where they might feel something on their skin or even inside. For example, they have a belief that someone implanted something in their brain, and they feel it. Last two, the gustatory or the taste sensation, and the olfactory hallucinations. These are rare. The catatonic and the negative symptoms are the last two. Catatonic behavior is divided into, there are 3 catatonic behaviors, including akinetic mutism, catatonic posturing, and wavy flexibility. In terms of negative symptoms, we have affective flattening, alogia, and avolition, and we will cover these in the next few. So the fourth symptom, the catatonic behavior, is a series of symptoms that involves lack of movement or communication overall, and we will describe three of these. The first is akinetic mutism, and this is exactly how it's described. Akinetic means no movement. Mutism means mute, lack of speech, and patient will experience both of these. Catatonic posturing refers to a very rigid and immobile postures, and we have this helpful GIF to illustrate that. See how the patient is very rigid, and he's also in a seemingly uncomfortable position as well. And the GIF also demonstrates waxy flexibility. So it seems like he's moving or encased in a liquid of wax. Right? The movement is slow, despite having initiated movement, albeit by the examiner. So the definition of this is the tendency to remain immobile in any posture, just like a wax has been encased over the joint and the muscles. So upon the stimulus, and there is significant resistance, and as the muscles slowly release and the limbs start moving very slowly. And finally, we have negative symptoms, which are deficit symptoms. And these involve minimal expression or interest in things around them. And these deficits can range from affective deficits, affective flattening that I've mentioned before. And this refers to patient having minimal facial expression, and anhedonia, which is a lack of interest in any activities, blunted affect, which is the diminished affect we talked about, and poverty of speech or allosia that was mentioned earlier. They are lacking in the amount of speech when communicating with someone else. And one more thing to add is avolition. This is when the patient has no motivation whatsoever to initiate something, to perhaps improve or enjoy an activity, even their hobbies. So that was criteria A for schizophrenia. There are many other criteria to determine if the patient has schizophrenia. Part B is whether a patient has one or more social or occupational functions that are significantly impaired. This includes the aspect of work, whether the patient is working as efficiently as before, hobbies, relaxation, if the patient is able to enjoy and relax as much as he or she would have liked, as well as maintaining relationships. This is referring to whether the patient can effectively maintain and nourish the interpersonal relationships. And C is duration. So at least 1 month of class A symptoms that we talked about earlier, but that's not enough. In total, 6 months of these symptoms needs to be continuously observed for the patient to be diagnosed with schizophrenia. And if you look at the picture here, 1 month in total would just be a brief psychotic disorder. Between 1 and 6 months is called schizophreniform disorder, and more than 6 is schizophrenia. And these are just how the diseases are classified. So the pharmacological treatment to schizophrenia is antipsychotics. There are 2 types of antipsychotics, typical and atypical. Atypical antipsychotics like olanzapine, risperidone, they block dopamine D2 receptors as well as 5-HT or serotonin receptors. The typical ones, like haloperidol, only block D2 dopamine receptors. Typical antipsychotic drugs are recognized as first-generation antipsychotic drugs, while atypical ones are second because they're newer. But they are also more expensive, although they have less severe side effect profiles. On the other hand, typical antipsychotic drugs are more affordable, but has more side effects, and are more likely to cause extrapyramidal motor control disabilities. Now that we've taken a brief look at schizophrenia, let's turn back to the eye. And in this presentation, we will explore the anatomy of the retinal layer, which is the innermost layer of the eye. The outermost is the conjunctiva and the sclera, and the middle layer is the uvea, anterior part being the iris and the ciliary muscles, and the posterior part being the choroid layer. And within the retina, if we face it straight on, there are different parts. You can see the vessels of the retina, and both the veins and the arteries can be seen if you use fundoscopy to examine the patient. And there are also something called the fovea and the macula. And the fovea is where the light focuses on when you're looking at something. This takes in information for your central vision, and this is lined with around 4,000 cones and no rods. And surrounding the fovea is the macula. Macula has the highest concentration of the cones, and this entire structure lies more temporally to the optic disc. Speaking of the optic disc, this is where the ganglion cell axons gather together and exit the eye as an optic nerve. And this connects to the brain as a second cranial nerve. Because this is a spot for the gathering of the nerve axons, the light hitting this area cannot be turned into a sensory information because there are no photoreceptors. This is referred to as our blind spot. And if you hold out your finger right in front of your eyes and gradually move it further and further away, there will be a point where you won't see that finger anymore, and that's because the light from your finger has hit your blind spot in the retina. And even within this one retinal layer, there are multiple layers. The light first comes in through and passes all the neural layers until they hit the photoreceptors, ironically, and then the signals from the light gets passed back to the plexiform layers, the bipolar and the horizontal cells, the ganglion cells, and that eventually goes into the optic nerve. And look at how many layers there are. We won't go into detail in this presentation, but just know that it takes this many layers to interpret and take in visual information. And this is a more visual illustration of the layers that were stated in the last slide. And so you see the bipolar layer, the horizontal cells, photoreceptors, the retinal pigment epithelium, as well as the Brooks membrane that divide that acts as a border between the choroid and the retina. And with the eye overall, the light first passes through the cornea and the anterior chamber. The iris can constrict or dilate to control the amount of light entering the eye. The light then passes through a clear lens, which then goes through the vitreous before hitting a specific part of the retina. So now that we've learned some of the anatomy of the eye, let's dive back into how schizophrenia is related to some of the eye abnormalities. So we should note at this point that schizophrenia is a hyperdopaminergic state. In contrast, Parkinson's disease is a disease that lacks dopamine. So they are opposites, which means sometimes when you're treating schizophrenia by depleting some of the dopamine production, this can cause some cause some Parkinsonian symptoms and vice versa. And when there is a high level of dopamine, there are 4 dopamine-specific pathways in the brain. In schizophrenia, the mesolimbic pathway is elevated, saturated with dopamine, and causes positive symptoms. In contrast, the mesocortical pathway observes a dopamine hypoactivity, and this causes negative and cognitive and affective symptoms. Some of the drugs can cause the other systems to go activate too much, and some of the typical antipsychotics actually can overactivate the nigrostriatal and the tuberal hypophyseal pathways. So although in the mesocortical pathway dopamine is hypoactive, overall in the system there's an elevated level of dopamine, and high dopamine in the brain means high dopamine in the retina, because they're very close and linked with the optic nerve. High dopamine in the retinal D2 receptors, especially in the cones, this causes hyper-intense perception of color. This in turn means that the patient will experience difficulty sensing contrast. So contrast, if you look at the picture right below that bullet point, you'll see a white background with black letters, right? And contrast is simply our ability to distinguish that difference in the shading. Some of the schizophrenic patients and others with impaired contrast sensitivity might have more difficulty than others to read some of the letters in the lower lines. We have already discussed that in schizophrenia, the macular volume and the macular area diminishes. And because the macula and the fovea are responsible for central vision, this atrophying causes diminished visual acuity. And in just the previous slide, we discussed that schizophrenia with the excess level of dopamine can cause decreased contrast sensitivity. Now it's time to talk about the movements of the eyes. And take a look at this picture here. The series of pinkish purplish dots are indicating what the participants see at any given time. So in healthy participants, when they were given a new picture or a scenery, their eyes move all over the picture. They try to see everything. It's exploratory. But in comparison, participants with schizophrenia, their eyes tend to gaze at a very localized fashion. Their exploratory eye movements, in other words, is very limited. And not only that, while looking at the scenery, when there was a visual pursuit, when there was a moving object, there was a little difficulty in maintaining that visual pursuit. The eye could not track the object that was moving, and because it kept slowing down, but the brain orders the eye to keep up to that target, the eye adjusts with the rapid late saccade to catch up to the moving object in focus. So these are some of the eye movement abnormalities that could be very interesting for future research. Now, one sign that you can observe in the eye with the schizophrenic patient, demonstrated by several studies, is widened retinal venules. So when you're looking at the back of the eye with a fundoscope, you will see that there are these vessels spread across the retina, like in this picture. But they're not blue and red. They're all very reddish. And the one way to distinguish between venules and arterioles is by the width. Venules are generally wider than the arterioles. But what I mean by widened retinal venules is that the discrepancy of the width between the venule and the arterioles are exaggerated in those with schizophrenia. So they will look abnormally larger and wider. So what I've described so far, the symptoms and signs of retinopathy and eye movement abnormalities, sound very qualitative, shall we say. You're probably wondering if there are ways to quantify these findings, and there are some investigations that can be done in terms of retinopathy. We'll introduce the OCT and the ERG. First, the OCT is optical coherence tomography, and this is a non-invasive imaging modality that uses light waves to take cross sections of the retina. This is great for measuring the thickness of the retinal layers, and actually, if you remember how I mentioned the RNFL is thinned in those with schizophrenia, well, you can observe that here. In ERG is electroretinography. This is a method where an electrode is attached at the cornea. This electrode detects the electric signals from the photoreceptors at the retina. Any abnormal signs would indicate problems in the retinal layer. And also in schizophrenia, the ERG tends to demonstrate a diminished rod B wave amplitude and longer latency. Okay, so we've learned how to observe the signs and symptoms in the eye in those with schizophrenia, and also even how to investigate that further. But how do we treat it, or at least slow the progression of such symptoms and signs? And the answer to that is probably similar to many medical conditions, which is to treat the underlying cause. Actually, with the antipsychotics, which is used to treat schizophrenia, is also found to have diminishing effect on the ophthalmic symptoms. However, we should also be aware of the effects of psychiatric medications on the eye. For example, chlorpromazine, which is a typical antipsychotic marketed sometimes under the brand names Thorazine and Largactil. This can cause cataractous change in the lens. This means that as the light goes through the lens, instead of having a uniform index, it causes the light to scatter and not converge neatly on the retina. The other medications can cause transient blurred vision, mydriasis or pupil dilation, and also blepharospasm, which is the spasm and the excess tightening of the eyelid muscles. Some can even cause pigmentary retinopathy, which is a proliferation of the retinal pigmental epithelial cells in the retina, and that can cause degenerative retinopathy, which is very harmful to maintaining sight. Unfortunately, the prognosis of the eyes during schizophrenia has not been well studied. The patients are not aware of the link between schizophrenia and the eyes, and because this is not well studied, and they tend to not regularly obtain ocular exams. It is also important to note that schizophrenia is not a curable disease. And overall, I'd say the prognosis would be adequate and pretty good when managing schizophrenic symptoms appropriately. This is also important for the patient's overall quality of life and ophthalmic health. It would also help a lot for the patient if they have regular eye checkups with their general practitioner. We have covered a lot in this presentation. but the main message is to establish a link and inform of this link between schizophrenia and the eyes. In summary, there are two main categories: abnormal eye movements, where there are also impaired smooth pursuits and limited exploratory eye movements. And second, retinopathies, so wider retinal venules, RNFL thinning, and also reduction in macular volume. Lastly, increased perception of brightness and color intensity, which leads to decreased contrast sensitivity. There are also studies that found correlations between schizophrenia and other eye diseases. And this has not been extensively studied either, but schizophrenia is associated with lens opacities and cataracts. And in the front of the eye, there can be pigmentation in the cornea. And the second point is the relations with strabismus. Children with strabismus, which is a misalignment of the eyes, they can develop schizophrenia later. And also those with schizophrenia are also at a higher risk of developing strabismus. Overall, the link between the eyes and schizophrenia is quite promising. When the research becomes more extensive and we get to characterize these general findings more and more, this might be a way to detect and diagnose and treat earlier some of the psychiatric disease, including schizophrenia. There is a saying there is an expression that says the eye is a window to the soul, and that might be quite literal if you look at the series of studies. So specifically, ophthalmic findings can be used as biomarkers. The unique eye movements, the diminished visual acuity while other sensory functions are intact, widened retinal venules, of course, thinning of the RNFL, and abnormal ERG waveforms, among others. These are quite a characteristic finding according to the studies, and they can be characterized in a more specific manner in the future. This is a summary chart of everything we talked about in this presentation. I hope you find this helpful. And lastly, here is the reference of all the resources that we've used to put this presentation together. Thank you for watching.